Dr. Mamata CN, Senior Resident from Department of Anaesthesiology and Critical Care at Mangaluru Medical College. We welcome you to the dais, ma'am.
Good morning, everyone. I'm Dr. Mamta from Bangalore Medical College. I'm here to present my topic, Oxytocin on trial, what's hot in LACS. Why should we know about our oxytocin? As we all know, postpartum hemorrhage is the major cause of maternal morbidity and mortality. And the causes for postpartum hemorrhage is 4 T's, that is tone, trauma, tissue, and thrombin. The tone, it has 70% as the cause of PPH. So we have to do the active management of third stage labor, that is oxytocin and cord clamping, control cord traction, and examination of the placenta. So we should know about our oxytocin. What are oxytocins? Oxytocins are the drugs used to stimulate uterine smooth muscle contraction. Where do we use? Indications: initiate or augment labor, facilitate uterine contraction, that is after the delivery of the baby, and reduce the risk of postpartum hemorrhage, that is as a part of active management of third stage of labor, then treatment of postpartum hemorrhage. These are the classification of oxytocins. We have 3, that is peptide hormones, ergot alkaloids, and prostaglandin. Under peptide hormones, we have oxytocin and carbetocin. Ergot alkaloids, we have methyl ergometrin and ergotamine. Prostaglandins, we have carboprost, misoprostol, and dinoprostol. Today, I'll be mentioning more about the carbetocin, which is the drug which has been replacing our oxytocin. Let us know about our peptide hormones. How do they act? The mechanism of action is they stimulate oxytocin receptors through the G protein coupled receptors. It causes increased calcium in our uterine myocytes and it causes powerful rhythmic uterine contractions. Then we have our ergot alkaloids, that is methyl ergometrin, which agonize the serotonin and adrenergic receptors, causing sustained uterine contraction. Then we have our prostaglandins, which act on prostaglandin receptors, increasing intracellular calcium and causing both contraction and cervical ripening. Oxytocin, it is used both intravenous and intramuscular. The onset of action of IV is 3 to 5 minutes, and when it is used intramuscularly, it takes 4 to 7 minutes to act. And the duration of action is 15 to 20 minutes IV. When used intramuscularly, it is 1 to 2 hours. The half-life compared to IV, 4 to 10 minutes, whereas it is 15 to 30 minutes given intramuscularly. The absorption is immediate when we have given intravenously, and it is rapidly when used intramuscular. The peak plasma levels are within 2 minutes of infusion, and it is approximately 20 minutes post-injection intramuscular. It is metabolized both liver and in our kidneys, and it is excreted less than 1% unchanged in urine. The adverse effects of oxytocin are hypotension, tachycardia, and dose-related water retention and cardiac arrhythmias. And the storage, it has to be stored 2 to 8 degrees Celsius. These are the guidelines which we use oxytocin. WHO guidelines, we use 10 international units IV or IM. When it's used in infusion, it continues up to 3 liters if bleeding persists. Then Royal College of Obstetrics and Gynec, they use slow IV bolus of 5 international units. Then American College of Obstetrics and Gynec, they use 10 international units infusion. And FIGO uses 10 international units IM and IV. The recent protocol, there was in one study, it showed that 3 international unit bolus over 3 minutes and 18 international units per hour for 1 hour and 3 to 6 3.6 international units per hour for 3 hours, it showed reduced blood loss and fewer side effects. Further studies are required to follow this. As we all know, the rule of 3. The initial IV bolus of 3 international units over 15 to 30 seconds, and it has to be assessed in the next 3 minutes. If inadequate, the tone we can repeat up to 3 doses, and transition to infusion for maintenance is 3 international units per liter at 100 ml per hour. Now, the carbetocin, which has been replacing our oxytocin, this is a heat-stable carbetocin. It's a long-acting synthetic analog of human oxytocin with its anti-hemorrhagic and hydrotonic activities, which was described way back in 1987. This is the chemical structure of carbetocin and oxytocin, and how carbetocin is different from our oxytocin. Carbetocin is oxytocin in which the hydrogen on the phenolic hydroxy group is substituted by methyl, and the amino group of cysteine residue is substituted by hydrogen, and the sulfur of cysteine residue is replaced by methylene group. Then carbetocin, it comes in 100 microgram. It is used either IV or IM. It's a single dose drug. The onset of action is within 2 minutes of injection, and the duration of action is approximately 60 to 90 minutes, and the half-life of 40 minutes, which makes us a better drug to use than oxytocin. And the adverse effects also, hypotension, nausea, vomiting, flushing, and headache are same as oxytocin, but it is less compared to our oxytocin. And the storage is the 30 degrees Celsius, which makes us use in the places where it is, which cold chain cannot be maintained. And the contraindications are hepatic and renal diseases, severe preeclampsia, severe cardiac disorders, and epilepsy. What do we use when our oxytocin fails? We have methyl ergometrin. It is used IM and IV, but most probably we have always used it IM. The onset of action is 2 to 5 minutes IM, and IV immediate action is seen. Duration of action in intramuscular is 3 hours as compared to 45 minutes to 1 hour intravenous. Half-life of 30 minutes. The maximum dose of methyl ergometrin can be used is 0.5 mg, and IV we do not repeat it. The adverse effects are hypertension, nausea, vomiting, headache, vasoconstriction, and chest pain. It is contraindicated in preeclampsia, cardiac failure, and cardiac diseases. Then we have prostaglandin analogs. We have carboprost and misoprostol. The carboprost is prostaglandin F2 alpha, it is in injectable form, and the misoprostol is prostaglandin E1 analog, which is used oral, sublingual, vaginal, and rectal. The onset of action is 3 to 5 minutes intramuscularly, and in misoprostol, if it is used oral or sublingual, it takes 18 to 16 minutes, and up to 30 minutes when used rectal. The duration of action 1 to 2 hours of carboprost and 2 to 4 hours of misoprostol. And the half-life is short in carboprost 10 minutes and 20 to 40 minutes of misoprostol. The maximum dose of carboprost we can use is 2 mg, that is approximately the 8 doses. And in misoprostol, it varies 800 to 1000 microgram. The adverse effects are nausea, vomiting, diarrhea, hypertension, fever, bronchospasm, abdominal pain, and uterine hyperstimulation. The contraindications of our prostaglandins are bronchial asthma, pulmonary, renal, and hepatic diseases. This when our tone, as I told, cause of PPH, if all these are used, then we have, still the patient is bleeding, then we have to go for the management of PPH, which comes in a mnemonic called E-motive, that is early detection of postpartum hemorrhage. We go with the motive like massage of the uterus, we introduce our oxytocin drugs, use the tranexamic acid 1 gram, then we use IV fluids, then we go for any trauma and examination of the genital tract. If the treatment is active, then the PPH is treated. Then if it doesn't, then we have to go for the PPH bundle, where we use the refractory PPH. We use bimanual compression of the uterus, then we use uterine balloon, then we go for anti-shock treatment. And meanwhile, we have to communicate with the transfusion medicine with the blood and blood products ready. If the patient is in a short setup, small setup, we have to shift the patient to the higher center. Then surgical, like we can go for B-length suturing, or we can go for internal iliac artery ligation, or we can go for peripartum hysterectomy. We even have embolization of internal iliac artery. We do say that it's a golden hour. Within 1 hour, we have to take the action. Otherwise, everything depends on the patient. Morbidity and mortality will increase if we lose the chance of 1 hour. Now, let us know what is hot in LSCS. That is carbetocin. It has become a game changer because it is used in prevention of our postpartum hemorrhage. Then the estimated blood loss post-delivery is less. The need for additional uterotonics is less, and there is decrease in hemoglobin level when we use it, it's less, and the need for blood transfusion is also reduced. Then there is a side effect profile, as I told, it is less compared to our oxytocin. And I will show the studies which have been done, and in 21st edition of WHO Model List of Essential Medicine issued in 2019, it added heat-stable carbetocin as the core list of medicine for our reproductive health. Then there is a champion trial done in around 16 countries about the heat-stable carbetocin versus oxytocin to prevent hemorrhage after vaginal birth. In this study, we saw that the heat-stable carbetocin was non-inferior to the oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonics. Then in Lancet study, the carbetocin versus oxytocin for prevention of postpartum hemorrhage, a randomized control trial was done. This showed that a single dose of carbetocin has been hypothesized to act as 16 hours of intravenous oxytocin infusion regarding the increase in uterine tone and the reduction of postpartum hemorrhage in elective cesarean sections. Then we have carbetocin versus oxytocin in cesarean section with high risk of postpartum hemorrhage. This study showed that the uterine tone was very good when patient was used carbetocin single dose versus the oxytocin infusion. Then we have the studies about adverse effects of carbetocin versus oxytocin in the prevention of postpartum hemorrhage after cesarean section, a randomized control trial. The adverse effects of nausea and vomiting was comparatively less, and the need for antiemetics was 0. Then the WHO recommendation uterotonics for prevention of postpartum hemorrhage in 2018, it recommended carbetocin. The use of carbetocin is recommended for prevention of PPH for all the births, vaginal or cesarean section. Then there was a study done in Canadian that carbetocin for prevention of postpartum hemorrhage, a review of clinical effectiveness, cost effectiveness, and guidelines. The Canadian guidelines uses carbetocin is recommended to prevent PPH for cesarean delivery and vaginal delivery with 1 PPH risk factor, and the German guideline uses it as a first-line treatment for PPH. There is a research trial which is going on, it's ongoing. We usually use carbetocin for the prevention of postpartum hemorrhage. This study is going on to use carbetocin for the treatment of postpartum hemorrhage. So we are waiting for the conclusion of this study. This is my institutional protocol. We use oxytocin 10 units intramuscular as an active management of third stage of labor, 10 to 20 units of 500 ml of NS, infusion at 125 ml per hour, misoprostol 800 microgram per rectal or oral, and ergotamine 0.2 mg IM or IV, and carboprost 250 microgram IM. This is a summary of my topic. As I told, the carbetocin, it has a long-acting oxytocin analog. It's a single dose which comes in 100 microgram. The onset is 1 to 2 minutes, duration is 60 minutes, and it is heat stable compared to our oxytocin which requires cold chain. Then the limitations are cost and the limited availability. It is used in prevention of PPH, not as such now as for the treatment of PPH. And we can use it in the peripheral setups where the cold chain cannot be maintained. These are my references. Thank you.
Thank you, ma'am, for the enlightening session on current trends and updates in the use of oxytocin during delivery. Next, the final speaker for this session is Dr. Archana KN,